welcome everybody, and thanks for joining us tonight for this public event from the Psychedelic Experience Clinic. We're a space for the development of a dialogue between contemporary psychoanalysis and psychedelic studies, and we also offer a low-cost referral service for those looking for support after psychedelic experiences. So before we launch into tonight's proceedings, I want to let you know that in March we'll be joined by Lawrence Fishman, MD. He's a psychiatrist and psychoanalyst who practiced and taught in the US for 36 years. Lawrence is going to be presenting a talk called Illusion and Disillusionment, a Winnicottian framework for psychedelic-assisted therapy, which we're very excited for. So we hope to see some of you there as well. You can keep up to date with our events by signing up to our newsletter via our website. You can just log on there. Tonight, I ask that you keep yourselves muted during the presentation. Afterwards, there will be time for questions and a discussion. And just so you know, we are being recorded currently. So without further ado, let me introduce tonight's speaker, Anna, and her talk, Anxiety is Vibration, Psychosocial Cartography, an Introduction. Anna Minozzo is a clinician and researcher based in London, UK. She holds a PhD and an MA in Psychosocial Studies from Birkbeck, University of London, and is currently a postdoctoral researcher in Psychosocial Studies within Free Psy at the University of Essex. She has experience with a number of community-based mental health services, and her research crosses the fields of medical humanities, feminist philosophy, and psychosocial inquiry. Anna is also part of the Psychosis Therapy Project and a member of the Psych for Contemporary Psychoanalysis, both in London, UK. Her book, Anxiety is Vibration, a Psychosocial Cartography, was published by Palgrave in 2024. So thanks so much for joining us, Anna, and please take it away when you're ready.
Well, thank you so much for having me to be in conversation with your group of colleagues. I don't think I've met you all, but I know Timmy, of course. We are colleagues at the site. So today's conversation is going to be about anxiety, as you know, and that's the theme of my book that was published last year, as Timmy just mentioned. I'll give you an overview of why I wrote that, why that topic was interesting, why it was important to think about it clinically and politically, without divorcing the politics and the clinical ever. And I'll speak for about 35 minutes or let's see, so that we have enough time to talk. I am not very familiar with psychedelic treatments or the interconnections between psychedelics and other kinds of therapy and psychoanalysis. But maybe that would be a really good point of conversation then, what I bring and what you bring. So to begin with, let's imagine these two kind of scenes of the contemporary world. In the Anglophone world, where there is this data, there is an understanding of a fifth of the population, so 20% of the population at least, being considered pathologically anxious. That's a lot. In other countries, you don't have this data for right now, but if you follow the historical counts of anxiety, it seems to be very similar. So if 20% of the population at least is considered pathologically anxious, whatever that means, what's available? What's done, to this huge amount of people? Well, in the UK, if we go on the NICE website where you see all the guidelines for healthcare, you'd see that for anxiety, you are mostly prescribed antidepressants nowadays. That was different some years ago, that you would be given benzodiazepines, but you'd be prescribed antidepressants. Mostly that happens in primary care. So your GP will prescribe that to you rather than secondary care, so specialist care. There's numerous accounts of people being prescribed after an antidepressant after 5 minutes, after 10 minutes, and after just phone calls, even. So it really is a first point of care. And people are often offered CBT, so cognitive behavioral therapy. And a lot of it is through this program called IAPT, which was, developed to make therapeutic access to mental health easier for people in the UK. Sometimes people are also referred to apps that they can use, even that are mostly based on CBT, kind of self-help style things that you could do to deal with your anxiety. Well, if you're a clinician, you know for sure, but if you are in the world, you probably heard from a lot of your peers that that doesn't seem to be working because people are more and more medicated, and all this national efforts of offering CBT have done very little to the mental health crisis that we understood to be in which there's this huge amount of people that are considered pathologically ill, in distress, or having pathological disorders. And this, what's available there doesn't seem to be working very much. And yet we are very anxious. Psychoanalysis, on the other hand, has been working with the idea of anxiety from its very beginning. So anxiety is, like sexuality, is psychoanalytic turf, you know? Psychoanalysis, it's, of course, in its various orientations, which is really plural, and the various ways it's practiced in different contexts, sometimes more applied, as they say, which is more diluted, so psychodynamic psychotherapy, and sometimes this kind of more orthodox, elitist type of psychoanalysis. So in its plurality, psychoanalysis aims to work with something that does not fit, something that is not right, without necessarily thinking of things as pathological in the same way that this hegemonic medical model of measuring suffering works. And of course, the psychoanalytic mode of thinking about suffering and distress has challenged these processes of pathologization massively. Even this very word disorder is something that psychoanalysts and people that work within a psychoanalytic frame have questioned for the last now almost 40 years, when this idea of a disorder grew in popularity in mainstream psychiatry and really kind of trickled down to everyday vocabulary. And now you'd see, like TikTok even. While psychoanalysis works with this thing that doesn't fit in one's experience, and, in a very benevolent way, tries to think about the function of a symptom, to think about a personal context, about contingency, about what psychoanalysts call singularity, it still gets to encounter the other carrying a specific frame of references. And when trying to figure out why we are anxious, so what's going on that you're anxious, psychoanalysis, even though it's trying to pay attention to that question, which, in other kinds of mainstream psychological healthcare, it's not a question that is asked. What is this anxiety saying? What's happening that this is going on? It's incredible to think, but that is not a given that that question will be asked. Certainly, it's not in a lot of mainstream texts. If you go and look at the classic CBT diagnosis checklists, for anxiety and depression, for instance, there's no single contextual question. So it's a type of suffering that is completely individualized. So psychoanalysis comes to it from a different position already. And yet, when trying to think about anxiety in particular, it still imposes a frame, and that is the Oedipal matrix. I'm not sure if everyone is very familiar with that. But the Oedipal matrix is this foundational metaphor from Freudian psychoanalysis that has been left pretty unquestioned by psychoanalytic canonical texts and massively criticized by feminist thinkers or decolonial thinkers nowadays too. And that bridge of something that has been so criticized and thought about and worked through in the field of theory and clinical texts seems to be super wobbly. It's a bridge of how to de-Oedipalize the clinic. It's very difficult to see happening. Those conversations are rare. There are very little resources to learn, to practice that way. The Oedipal metaphor is nothing more than a metaphor for relationality that the psychoanalytic subject is supposed to inhabit. It's an idea of how we come into the world within a certain family arrangement, how transmission of a position is transmitted, how there is sexual difference, a binary of sexual difference, how through being this or that, man or woman, this little nuclear family, heteropatriarchal, reproduces itself. And what it needs to reproduce itself is to really modulate our desire. So the Oedipal metaphor really is a way in to think about forms of identification. So who can I be in this little model of the family? I can be this or that. And if I'm this or that, I have to desire this or that. So it's a mode of relationality that's to do with how you can be and how you can desire. And that's the paradigm for the Oedipal model, which is funny because Freud came up with this because he actually went to the theater to see the play of Oedipus, the Greek play. And then he thought, that actually is very useful as a metaphor. And for as much as in psychoanalysis nowadays, we think of certain concepts and certain ideas as not being really it, it's not really the phallus, is it? It's not really that nuclear family. It doesn't have to be mommy and daddy. Yet those words are not neutral. And the Oedipal paradigm is not neutral at all because it functions in this logic of castration. So the phallus there, this thing that a man has and a woman doesn't because the woman lacks, is what guarantees access to a position in the world as a full subject. In this metaphor, of the Oedipal arrangement. And it's something about the threat of losing that privilege that causes anxiety. That is in the beginning of psychoanalytic texts. And a lot of the interpretations that are provided in the clinic follow this Oedipal metaphor, that it can be this or that you lack or you have. and this order of sexuation being a binary, either occupying the feminine or the masculine position, and how you have to desire in this or that way. But of course, nowadays, slowly, there are some colleagues that are offering more queer critiques to the possibility of working psychoanalytically. But that is somehow still new. So we're very anxious. What's been provided in terms of care seems to be not very adequate. People arrive in more psychodynamic or more humanist clinics after having tried a lot of things, after having tried a lot of CBT, after having tried medication, and still something still feels too much. And psychoanalysis, which is this place where we can ask questions about what's not working, what doesn't fit, seems to be also working with a frame that is still imposed into the world that this person that we are working with is sharing with us. So that is a big question already. Is that enough for psychoanalysis? And if psychoanalysis has so much to say about anxiety, perhaps we have to start by making it possible to work with anxiety too from a non-Oedipal perspective. That was my bet. I didn't have the answer at the beginning. So if we go to if we go to all the psychoanalytic texts on anxiety, which is something that I did in my research, I went to Freud and Lacan mostly, so not object relational theories. I chose those two theories and tried to understand what they said about anxiety and when. Because as you know, Freud changed his mind a lot, which is perhaps why we keep on being so drawn to him. His ideas can be confusing, paradoxical, so there is something there, whilst he positions himself as a master, he's also always not being a master and changing his mind, which is quite compelling too. So if we follow what Freud and Lacan said about anxiety, and the several theories that they propose, Freud will talk about castration anxiety, separation anxiety, and mostly and signal anxiety, a threat. What's common there, if we follow the different phases of their theories, is that there's something excessive in anxiety that has something to do with a world as is collapsing. A world as it is delineated, as I know it already, forms of relating, forms of being in the world, an understanding of oneself, which, in Lacanese would be an imaginary, something that has got an imaginary consistency. When that is interrupted, when there is something of the order of excess, of chaos, of a disruption from outside or from inside, because that also will vary across their theories. And at the end, Freud said, well, it doesn't really matter if it's from outside or from inside. The effect is the same. It's this, experience of being in the world that we have that becomes really fragile. And anxiety is that moment. And it's interesting because then anxiety can become the problem itself, and we can have anxiety for having anxiety. And we see that, for example, in people that come to us experiencing a lot of panic, and having a constant anxiety about having an anxiety crisis too. I wondered if anxiety being this field of psychoanalysis, is in the first few texts that Freud ever wrote, if there was something there in this excess then, that could be a source of mobilization for another arrangement of life. So instead of thinking of what can patch up the world as is, give more imaginary consistency, strengthen the ego from this kind of disruption, if the disruption itself, that thing that doesn't fit, if that could be the point of work. And in order to think about that, Then I started this kind of feminist investigation of a possible clinic of anxiety. So, can we get rid of this Oedipal metaphor in which a way of being in the world is already prescribed in a certain kind of social reproduction, and work with excess without thinking about castration? Because a lot of psychoanalytic texts, they talk about, if you're too anxious, you need castration, as if every excess has to be kind of contained, interrupted. Can it be instead mobilized? And that's a different word than to be contained. To contain is just to contain. And yeah, maybe at first instance you contain, but to be analytic about it, you mobilize it into something else. So that jump is what I was really interested in. Um, so yeah, in order to do that, I just went through all the Freudian texts and all the Lacanian texts, and I understood that actually in most of their work, they weren't relying on Oedipus to think about anxiety. It was a particular moment in Freud in 1926 only that he had already delineated this very Oedipal metaphor. And he was working with, the ego, the superego, and the id. And he already had delineated the death drive. So when his theories were very advanced, that he becomes very Oedipal about it, and he talks about castration anxiety. Before, anxiety is really a threat to the world as is, something that puts your experience as the world presents itself in a fragile state. And towards the very end of his work, true, the very, very last text, he has this interesting passage that he talks about the id, so the unconscious, having a system of perception of its own. And I loved it when I found that quote in Freud, 1938. It was I think it was in the outline of psychoanalysis. Right at the end, thinking that there's something about the unconscious, and the drives, this that really escapes symbolization and these imaginary frames, that perceives something of the world too. So there's something about the unconscious that is not alienated. In Lacan, he of course begins where Freud had left. So he begins pretty Oedipal. And he has a whole seminar 10, the early 60s, that is on anxiety. And then he talks then about anxiety being an effect that signals the real. The real appears. This excess, chaos appears. And towards the very end of his work, he becomes a bit more interesting. I don't know if you're into Lacan. Towards the end of his work, he really is not interested in structures, of putting people into specific psychic structures, and he becomes much less Oedipal too. But the writing is super obscure and confusing. And interestingly, there was a lot of work happening in philosophy and in feminism and in radical psychiatry around him at the time, in the 70s already, in the case of Lacan. But because he was a bit of a right wing, maybe idiot, he didn't pay attention, and he just kind of tried to figure those things out in a very kind of insulated way. But he was trying to get to the same point that Deleuze and Guattari and feminists were, about an unconscious that is a post-structuralist possibility for the unconscious. So outside these frames that just reproduce themselves, but to think about difference, to think about rupture, to think about that which doesn't fit precisely. So anxiety, as just to be really quick about it, anxiety is in medical texts from the 18th century already. It wasn't a thing on its own. It composed a lot of possibilities for madness, but it wasn't an illness in any way. When in the late 19th century, there's a popularization of the diagnosis of neurasthenia, which is this diagnosis of, being weak of the nerves. Um, that's when Freud comes to the picture and he's like, well, actually, there's this thing called anxiety neurosis. That's his first name for anxiety. That is different from neurasthenia because there's something of the order of sexuality, of the sexual. There's something excessive, libidinal, you know? And as you know, libido for Freud, it's not differentiated between life and death until the very late in his work. He first talks about the, you know, of ego preservation. He talks about, the sex and love. There's different divisions of the drives until he gets to the life and death drives. And it still is not really explained if there is a different content to the death drive than to the life drive, or if it's just a matter of a mode of operation, one that is based on repetition and stillness, and one that is in ground zero, and one that is based on expansion and difference. And this, Guattari tried to think about that, but again, being very confused. So we can say, if we look at Freud's early texts, that the energy of life, libido, is the same in life and death. So if we think about the erotic of sexuality, we don't have to differentiate the actual contents of vitality in that way, but it's modulation, what happens to it. So Freud was already onto it right at the beginning. This is like in the pre-psychoanalytic texts before he became a psychoanalyst. And he's already saying, well, there's something else about anxiety neurosis that is to do with the order of sexual, which means that there's types of investments of subjectivity in the body. And he says anxiety is an affect. It's this thing between body and psyche that exceeds consciousness, and it's invested libidinally. It's to do with our desire for being in the world. Um, Psychoanalysis was very influential in the beginning of the 20th century in mainstream psychoanalysis, in psychiatry, sorry. So, of course, there was a big jump there from Freud appearing and treating the first hysterical patients, establishing himself first quite marginally, in a group of friends in Vienna, when in the Wednesday group that they used to meet, creating the first psychoanalytic society, the creation of the International Psychoanalytic Society in 1910, to the psychoanalytic having a lot of space in mainstream psychiatry. You'd have the first editions of the DSM, which is the US manual for psychiatric diagnosis and treatment. The first two editions were very psychoanalytic because the psychiatrist that was composing it was informed by Freud. So you'd had the psychoneurosis and the psychosis. You thought about these big umbrellas, and within that, there was a lot of focus on the psychoneurosis because that's what you encountered in outpatient treatment, mostly different from when you work, in the hospital. And depression until that time was really uncommon as a diagnosis. It wasn't something that was common at all. Until the 1950s, you'd have the amount of people being diagnosed as anxious was 3 times more than those diagnosed as depressed. Depression was akin to melancholia, which, in Lacanese is of the order of psychosis. It's a very extreme melancholic position that you're in, and not something so common. That will change in the late 1970s. And again, if we think about what's happening in the world in the 70s in terms of politics and economics, you have the rise of neoliberal politics across different countries in the global north and Latin America. And the DSM changes. The idea was that it was going to become more scientific and depend less on a doctor to kind of interpret what was going on with the patient. So they proposed a checklist system. Do you this, this, and this, and this, tick, 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 tick. This is your diagnosis. But it was done in such a way that different diagnoses for anxiety were created, like social anxiety, for example. And whilst the mainstream diagnosis for anxiety, which was general anxiety disorder, could only be diagnosed if you didn't have any other type of anxiety. And of course, that's really, when you look at those patterns in diagnosis, it's also crazy because you think, okay, how can it be that 10 years ago, everyone has this thing, and now everyone has this other thing? What happened to all that anxiety? Because after this checklist system was created, it also offered the possibility of major depressive disorder, which is a diagnosis that still exists. And that was made easier to be diagnosed. You could be diagnosed with that even if you had other symptoms and other things going on. And to make it more conspiracy-like, that coincides also with big change in pharma. So the drugs that were being tested to cure distress. And the paradigm, the drug-centered paradigm, is only from the 1950s. This idea that you give people a drug, and then depending on what happens to them, you give a diagnosis of what's wrong with them. And nowadays, you have a very common one, which is actually really serious, of treatment-resistant diagnosis, as if that's something that exists. You give a pill. If it hasn't worked for you, then there's something else that is wrong with you. This paradigm is from the 50s only. And Big Pharma started sponsoring the DSM from the 1970s massively. So much so that now we are in the fifth edition only. It's from 2013. The DSM-5, more than half of the budget was paid by Big Pharma. And I think 80% of the doctors that created the DSM, the latest one, they're also paid by Big Pharma. So, of course, that is not a neutral arrangement. What happens when so depression becomes this easy thing to be diagnosed. Anxiety becomes a bit more complicated. And you start having, slowly after the DSM-3 is launched in 1980, you start having this new drugs the, that follow the serotonin paradigm. This idea that there's this little thing in your brain, and if you don't have enough, you just need to replace it, which only very recently is being formally challenged uh, in the scientific arenas. There is one psychiatrist here in the UK. She's become very popular, actually. Her name is Joanna Moncrief. She was very famous for years because she was running I think, a project to monitor people with psychosis that were choosing not to be on medication and thinking about, you know, what would happen, which is really important. And she has a really amazing work on psychiatric drugs. And she think about the drug as a drug. Yeah, if you drink a glass of wine, something's going to happen to you. If you take an antidepressant, something's going to happen to you. If you take an antipsychotic, something's going to happen to you. But that not being the evidence of what is you, because this substance has an effect in your body, it doesn't mean that there's something ontological about you, a diagnosis related to it. Rather, there's a drug effect. Yeah, you can be calm, you can be agitated, you can be high. A drug is a drug. And this idea that psychiatric drugs have become something else than a drug. And they have become these things that are supposedly fixing something that is happening to you. And so this all coincides. And the SSRI drugs, which are still the most popular things that are prescribed, took over from the previous generation drugs like benzodiazepines, which were highly addictive and had really serious side effects, and the first antidepressants too, which people became just really low. So there's a lot of side effects from those drugs. SSRIs, the rise of Prozac was this idea. You had a lot of adverts. You have this idea that this doesn't have side effects. It's safe. And Big Pharma coincided with the DSM-3, funded a lot of populational awareness programs. So from paying PR agencies to create patient groups to demand certain treatments, distributing leaflets, educating all healthcare staff in the US. But here in the UK too, you'd have national programs to defeat depression. So you create this problem, it becomes very popular, and then you sell a lot of drugs to it. So this is the context of the 80s and 90s. And slowly, antidepressants also starts being given to anxiety. Only then, so after the 90s and 2000s, that anxiety becomes popular again. Because the shift, if you look at the numbers from the 80s and 90s, nobody's anxious anymore. Everyone is depressed. You'd have this kind of Time magazine covers, depression is going to kill more than heart attacks in America. Depression is costing England more than anything. So this the problem of the century. And then anxiety catches up again only when it can be treated with the same drugs. And that's the process of patents for the same drugs. So drugs are patented for social anxiety, for PTSD, etc. When you start researching that kind of stuff, it's really it's infuriating, and it's also mad because it's really the way we are taught to understand our affects through language is really important. So people come to us and they say, I have this. This is what is going on with me. So we as society, we are given words to explain phenomena. And we take that, and that impacts our experience of our effects too. Uh, Sometimes it limits our experience of these effects. I wonder why the claim about anxieties, I just want to get rid of it. I don't want to think about it. I just don't want to be anxious. And that is the demand because also that is the promise too. You'd have, I think it was the Paxil advert. It was Paxil, your life is waiting. This idea that you can get rid of it. And a lot of CBT also works like that. Of course, there's practitioners and practitioners. There's some more irresponsible and some that are very good. But the idea of it, if you go to hardcore CBT, is that if you just think and behave differently, you're going to think and behave differently. Yeah. So there is this correlation of, systems of thoughts and repetitions of beliefs and behavior, and how there's no opacity, there's no gray areas, there's no unknowns, there's no excess. And if it's possible to reprogram how you feel and behave, then if that's not working for you, then you're extra incompetent. So the increase in your suffering and distress when that doesn't work for you too, even something that is not drug related. So there's a lot for us to think about the psychopolitics of anxiety in the last century. And when it came to my work, I tried to look for alternatives really outside of the psychoanalytic canon and, of course, mainstream psychiatry. I offered in my book a landscape of what can be done, what has been done, what psychoanalysis has offered, and wondered, is psychoanalysis capable of offering something else too? Can we work with this excess? And so to do that, I mobilized the philosophical tools from the French philosopher Gilles Deleuze and from feminist thinkers to think about this question of affect. Freud says anxiety is an affect. Lacan, anxiety is the only effect that doesn't, fool us. What is affect? You know, how can we think about it? How has it been considered? And is there something about the unconscious that is not individualized? And in the UK, especially in particular schools of psychoanalysis, we're stuck. Either we're working with an inner world that is completely individualized, as if your experience in society, your political experience is irrelevant, or you're working with this idea of a shared symbolic, as if there is something that sustains something universal in the world, and you can only live in relation to that. And I thought that that was really lame to think about the unconscious. In psychoanalysis, Guattari says, doesn't own the unconscious. The unconscious is there, it's everywhere. Everyone has an unconscious. Every culture accounts for the unconscious in so many different ways. So psychoanalysis doesn't own this idea. What Freud offered was a clinical understanding of unconscious processes and psychopathology, and a technique, a ritualized technique to work with it. But he didn't invent it. Yeah, the unconscious is there and it's in constant production. So the way I went about it is to think about this idea of vibration, which comes from the work of an artist from Brazil that thought about the vibrational body. So really it could be this embodied unconscious, this field of affect, this way of being affected by one another without that crossing consciousness. And I worked from there to think about the possibility of affects and what that would mean in the clinic. When it came to the clinic, then the conclusion of my work is that then to work with anxiety, it's not just about thinking, why are you anxious? What's happening? What's the function of this anxiety in your life? Which are already tremendous questions to be asking, when you're working with someone through time to be curious about this anxiety rather than just getting rid of it, but to understand it as something that doesn't have to be interpreted by the analyst, you know, much less so with an Oedipal matrix in my imagination. To think about its castration, its lack of separation from the mother, and all that kind of nonsense. Um, but the idea that you could work with what I name copoiesis. There's this position of the clinic in which something is constructed together. So the clinician and the patient, they build something together that is new. It's the series of attempts at creating different possible meanings. And I just gave these words because those are words that are in kind of ecological feminist vocabulary. But what I found is that if we really pay attention in Freud, really seriously, in the moments that he wasn't into Oedipus, and even Lacan at the end, that's kind of pretty much what they are saying that we should do. Yeah? To not interpret everything, but to build something together from this point of this excess. That excess in the clinics has to be mobilized and assembled into something else, and is a process of assembling that is done together in the encounter. Yeah. And this idea that you bring your unconscious to, as an analyst, to encounter the unconscious of your patient. So you're there not just applying a technique, not knowing as everything that you're doing, but you're there, embodied, also divided subject, and you're working together. That's kind of the conclusion of the work. I hope it makes some sense. This is a very kind of quick introduction to this book. The book, if you're interested in it at all, it's available as an open access book, which means that it's free to download on the publisher website, but you can also buy it anywhere. Um, I don't get anything from it, so if it's up to me, just download it for free and share it with your friends. And you can have more details of all those things that I've talked about if you're curious about any part of the book necessarily. Yeah, I hope this was interesting to you. And now over to anyone that wants to say anything. It doesn't have to be a question, it could be something more free, associative, perhaps.
Thank you so much, Anna. Um, yeah, when I saw your pass actually at the site, um, I heard something in it that, you know, deeply resonated with me and how I think clinically and the sort of direction where I want to like grow into and learn more about. So yeah, your presentation today has been super useful in that, and I really look forward to sort of digging into your book too. Um, yeah, I love these ideas. That sort of, openness of the unconscious onto something that's perhaps more collective, but not necessarily in a sort of totally Jungian kind of Platonic forms, idealist, transcendent kind of thing, but something perhaps more immanent, affective, this
Yeah.
kind of thing, like an openness to essentially the unknown. Um, and that having this, yeah, excessive aspect to it, this sort of like disruptive aspect. Um, I really loved all that. And I can't help but hear in this idea of a receptive function of the unconscious, a lot of uh, resonance with the ideas of thought transference and telepathy and that kind of thing. Did anything along those lines come up in your research too?
I didn't go that way, but I worked with the theories of a philosopher, Spinoza,
Mhm.
and this idea of effect that Deleuze takes from him, this capacity of being affected by one another. And I think as a feminist, that's really important because this idea of telepathy or this kind of unconscious transmission that's in Jungian place, to me personally, as a feminist, I think it's very insufficient because the encounter, as feminists, it's about responsibility for one another. True. It's how we encounter one another and without relying on this interpretation frames, without giving the book. Then, when I give up on that, I can be responsible. I can be implicated in that encounter. So there's something about an ethics of the unconscious, perhaps, that we're thinking about. And it's interesting because it's really different from psychoanalysis. In Lacanian psychoanalysis, there's no ethics of the unconscious. He tries to get to the ethics of the real, but it's a real that over and over, but at least in the 1970s, that is really subsumed into the symbolic as this kind of crack off the symbolic, an excess. So that still kind of universalizes um, and imposes some sort of subject of culture and consciousness still into an encounter. And feminist thinkers from a billion different traditions talk about this kind of ethics of the unconscious in so many different ways, using so many different repertoires. I chose this particular kind of post-structuralist feminist, and it's very, it's like when we give up the phallic signifier, we can assume a position of a nomadic subject, and then we can be responsible for humans and non-humans. Very clearly, that's stated, in that kind of world. But I guess I don't know if I want to work with Audre Lorde, who comes from a total different intellectual trajectory. You're talking about the erotic, too. And the erotic is not just this thing, it's about an investment in the encounter with the other that is really about responsibility for the world that we create. So, also responsibility for the worlds that we desire, the responsibility for the worlds that we symptomatize. So, I think I kind of went on that route, and I don't know if that speaks to your question, which is a really good question.
Yeah, it's super interesting. I mean, I'm like brimming with things to say about this, and I don't want to hog the mic. So I'll let others speak too. But I hear something in what you're saying there about like a kind of ethics wherein one has to assume responsibility for actually participating in the other's affect. Hmm, interesting. I
It's
like
about
that.
the encounter,
Hmm.
and
Hmm.
that really also uh, makes it possible this transversal clinic, and not the analyst patient. So if you think, you've got to this idea of transversality, um, yeah, you there's a question of responsibility towards one another. And yeah, in feminist philosophy, people have been talking about that, But it's interesting that in this little mini political laboratory that is the clinical encounter, we find it difficult to think that way. But I guess, I don't know, depending on our clinical practice, and I wonder what's yours, everyone, you can't not practice like this. depends on who you work with, the things that come to you, that you're presented with, the milieus that you're working in. You can't but practice in this implicated, politicized, with responsibility to the other. If you're working with people that are, you know, uh, living despite so much structural violences in so many ways, not to just reproduce that violence, it takes that from us.
Has anybody else got a question that they want to ask?
Yeah, I can go. Hi. Hi,
Yeah.
Anna. I'm at CFAR. I think you were at CFAR
Oh, cool.
before.
Yeah.
Yeah. Nice to meet you.
Lovely to meet
Yeah, first, thank you so much. That was really helpful. But I was wondering if you could say a little bit more about um the excessive that leads to the collapsing. Because I know that, I mean, when we use the word excessive, or we kind of sometimes mean that there's always more to what we're saying than what we can say, and there's that kind of excess that can't be articulated necessarily sometimes in language, and that being a space of the unconscious maybe as well. But it seems like when you were saying kind of anxiety as a result of excess,
you. Mhm.
and an excess that leads to collapse. I was wondering if you could put some words to what kind of excess that is. Like, what does that mean sometimes clinically also, for you, in like ways that you've seen it, or understand it, yeah, in a more clinical setting.
That's really a great question, Fahad. And I think I would go to Freud's early text, the early text, the Project for Scientific
Yeah.
Analysis, and go to late Lacan. That's when you get this excess that is not to do with language.
Okay.
It's really excess in terms of is the sexual,
Mm,
it's libidinal excess, the
right.
excess of the drive. And that's what anxiety really mobilizes. Anxiety is heart palpitations, digestive problems, breathing difficulties, sweating.
Mhm.
It's a very embodied kind of suffering. And yeah, this excess of the order of the sexual. And that's in really, really early Freud and really, really late Lacan, but not in between any of that.
Mm.
Then we're stuck in excess to the frame of Oedipus,
Hmm.
as if sexuality has to be bound to something
Yeah.
that cuts, or access to language. And at the end of Lacan's writings, he will give us something about this real that is not just an impossibility within the
Yeah.
symbolic. Um, and he even talks about creating the possibility of creating new imaginary bridges from the real that don't have to cross the symbolic. Do you know what? This is not small and not just about anxiety, but it's huge, when we have Lacanian analysts talking about trans people using the most transphobic nonsense you could ever hear. It's to do with this, a real, an excess of, libidinal vitality, whatever we want to call it. Because energy is such a difficult word to say, but energy, if we're going to be really truly like early Freudian about it, but mobilizing something of this order of what doesn't fit in me
Mm.
and creating, producing new ways of being in the world from that point without having to pass through a symbolic that is mediated by the phallic order, the division of culture, the places that are already available,
Mm.
etc. So I think it has a lot of consequences how we interpret those super niche concepts in the
Yeah.
text that we work with.
Thank you. That's really good. Thanks.
So we're gonna have to stop in just a moment. But something came to mind throughout, where you're talking about anxiety, the development of the DSM, diagnostic categories, this kind of thing, and also this sort of waxing and waning of psychoanalysis and the birth of pharmacology and psychopharmacology. And of course, it's around that time of the 1950s where you have the introduction of the psychedelics into psychiatry too. Um, and it's super interesting because you get this bifurcation in the field where one model is about inducing a huge amount of excess, a sort of mystical experience. And that's a kind of pharmacological model in a way where it's like the drug effect has the effect upon the disease entity. And then you've got these people that stay quite close to a psychoanalytic model, and they think about the introduction of a psychedelic in sort of psycholytic terms. So it's something that, you know, breaks down the ego, like allows for repressed material to emerge, like this kind of thing, that then can be used in ongoing psychotherapy. And when you were talking about this idea of excess, anxiety sort of breaking apart the world, I couldn't help but think about these quite like apocalyptic experiences that people have with psychedelics, you know, ego death, this thing where the world afterwards is totally new, like completely novel, in that, you know, positively inflected, like uncanny. It's a super interesting thing. And just thinking about, well, perhaps what psychoanalysis has to offer the psychedelic clinic is precisely what you're talking about in this relationship and use of anxiety. You know, perhaps what psychedelics do, how they work, is to induce a kind of anxiety that can be channeled in this sort of, you know, creative or co-creative kind of productive.
Well, Timmy, what I say to you is write that paper then.
It's on the way.
Like it's calling you, and I would love to read it. Sounds really, really cool. Guys, I'm gonna have to leave because I have a patient just now, but feel free to get in touch. Any of you, of course, I haven't heard from Debbie, Oliver, Patrick, and Keith. But yeah, feel free to get in touch. I'd love to hear about your work and anything else you have to say, and to continue this conversations. Yeah, whenever we have a chance. It's yeah. Thank you for having me and for listening.
So much. See you later. Bye, everybody.
Bye.